First, we must address port placement. We start by placing a 10 mm port at the umbilicus. Then we place 2 more 10 mm ports laterally in the lower quadrants. We then place 5 mm ports lateral to the umbilicus bilaterally. We place the ports in this manner to facilitate dissection and suturing for this course. Before we begin, let's review some of the avascular spaces we will encounter today. In this drawing, you see organs such as the bladder, the uterus, and the bowel, and color-coded avascular spaces. At the top of the page is the space of RSus, the space between the pubic bone and anterior to the bladder. The next space is the paired paravesical spaces lateral to the bladder and uterus bilaterally. The next space is the vesicocervical space, posterior to the bladder and anterior to the uterus. The pararectal spaces are paired in blue, lateral to the uterus and bowel. The last two spaces are the rectovaginal space, which is posterior to the uterus and anterior and lateral to the bowel, and the presacral space just anterior to the sacrum. Just as we encounter adhesions in humans, we can encounter adhesions in cadavers and need to tackle these before our dissection. Sharp dissection is used using laparoscopic scissors, being mindful to respect the tissue planes to avoid inadvertent injury to surrounding structures, especially the bowel. The surgical principle of traction and countertraction is demonstrated here, which helps expose the appropriate surgical plane. These surgical planes can be more challenging to appreciate in cadavers as well, which is another reason this principle is so important. So now we go back to our avascular spaces picture again. Let's zoom in on this area of interest and blow it up to look a little more closely. After zooming in, we see some critical structures and can delineate some avascular spaces a little more closely. We can identify the ureter, the internal iliac artery, the obliterated umbilical artery, and the uterine artery. After identifying these structures, we can identify where we are in the pelvis. The paravesical space we know is lateral to the bladder, bordered by the obliterated umbilical artery and the uterine artery. Inferior to this area are two spaces in one, the pararectal spaces. The lateral pararectal space, also known as RSus space, is bordered medially by the ureter and laterally by the internal iliac artery and the uterine artery. You can appreciate the uterine artery is the divider between the paravesical space and the pararectal space. The medial space, or Okabayashi space, is bordered laterally by the ureter and medially by the peritoneum and the bowel. So now that we have dealt with our adhesions and reviewed our pararectal and paravesical spaces, let's move on to our dissection. We should begin the dissection at the bifurcation of the common iliac vessels in the pararectal space. The first step is to make an incision medial and parallel to the infundibular pelvic vessels. As you can see, medial traction on the peritoneum is aiding in our dissection with laparoscopic scissors. Not shown here is that the dissection should be continued cephalad until the bifurcation of the aorta is reached. We then want to identify the ureter running along the medial aspect of the peritoneum, and the iliac vessels are seen laterally. We then continue the dissection caudally, dissecting the fat, non-fat interface along the medial edge of the internal iliac until we see the uterine artery. We continue dissecting parallel and medial to the uterine artery until the ureter crosses underneath the uterine artery. The uterine vein is visualized here as well, branching from the internal iliac vein. Here we see an excellent view of these structures, with the internal iliac artery laterally, the uterine artery branching off, crossing over the ureter, and an excellent view of the uterine vein just lateral and inferior to the uterine artery, coursing just beneath it. Given this is such a great view, I wanted to point out some of the most important avascular spaces we previously discussed and that we will encounter, not just today, but as surgeons in general. Highlighted in white is the paravesical space, and highlighted in pink is the lateral pararectal space, or RSus space. These spaces are some of the most frequented avascular pelvic spaces, and their divider is the uterine artery. Now let's move into the paravesical space, which is bordered medially by the bladder and contiguous with but lateral to the space of RSus. The lateral border is the obturator fossa and the external iliac vessels. So to enter the paravesical space, we should identify the obliterated umbilical ligament, which is located within the medial umbilical fold. If you are having trouble locating this within the pelvic space, you can tug from the anterior abdominal wall and follow to its origin at the internal iliac artery. Now we can enter the paravesical space by incising the round ligament or the peritoneum along the medial aspect of the obliterated umbilical artery. This space can be developed with blunt and careful sharp dissection. If we continue dissecting in this area medially, we will notice our previously identified structures, the uterine artery and vein, and the internal iliac artery. We then follow the internal iliac artery to its terminal branch of the obliterated umbilical artery. Off this artery branches the superior vesical artery shown here. Here we see an excellent view of these structures with our previously seen internal iliac artery and the uterine artery and vein. The internal iliac artery continues into the obliterated umbilical artery and the superior vesical artery branches off. Next step is dissection of the obturator space. Once again, let's refer back to our drawing and zoom into the paravesical space, in particular the lateral aspect of it. We can see the borders of the obturator space are the external iliac vessels laterally and the internal iliac vessels and the obliterated umbilical artery medially. Within this space, we will identify the obturator vessels and nerve. Going back to our cadaver, we can identify the junction of the external iliac vein and the lateral aspect of the internal iliac artery. Let's dissect on the medial aspect of the external iliac vein. It can be helpful to retract the lymph nodes and fatty tissue medially, and we can continue to dissect posteriorly to find the obturator nerve. Here we can identify the external and internal iliac vessels, our obliterated umbilical artery medially, and the obturator nerve centrally. Let's dissect caudally along the lateral aspect of the obturator nerve until the obturator artery is identified and follow it medial to the nerve. In this space, we can identify the external iliac vessels, the obturator nerve, and the obturator artery. The obturator vein can be identified posterior to the artery and nerve. We can continue the dissection of the obturator nerve and artery laterally and deep. Here, we will reach the obturator foramen and the obturator internus muscle and Cooper's ligament superiorly overlying the pubis bone. Next is the dissection of the inguinal canal. To start, we want to identify the lateral umbilical ligament or the inferior epigastric vessel on the anterior abdominal wall. So here we can identify the lateral umbilical ligament, the medial umbilical ligament, and the external iliac vessels. From there, we incise the peritoneum medial to the external iliac artery and enter the space between the artery and the vein. You will want to follow the external iliac artery superiorly until the inferior epigastric artery is identified. Here we can appreciate the inferior epigastric veins, 2 on each side of the singular inferior epigastric artery. Next, let's incise the peritoneum overlying the inferior epigastric vessels and dissect medially from the inferior epigastric vessels at the level of Cooper's ligament. Here we might find something dangerous and unexpected. So let's identify our landmarks. We can see the inferior epigastric vessels, the obturator artery medially, and this anastomosis called the corona mortis, or crown of death, which runs medially and inferiorly along Cooper's ligament. Here's another example in a different cadaver of this anastomosis, as it can be between the inferior epigastric artery and the obturator artery, or the external iliac artery and the obturator artery. We identify the external iliac artery laterally and the obturator artery medially, and the nerve just below. Cooper's ligament is identified as well, and then the anastomosis is confirmed to be the corona mortis between the obturator and external iliac artery. Surgical laceration of this often results in fatal hemorrhage. Let's move cephalad and medially to the presacral space. Let's migrate back to the area we dissected already and refamiliarize ourselves with the anatomy again. Once again, we can see the ureter medially in the peritoneal leaf, the internal iliac artery with its terminal branch as the obliterated umbilical artery, as well as the uterine artery and vein. If we flip the peritoneum medial to the ureter, we can see the parasympathetic fibers of the hypogastric nerve traveling laterally below the ureter. If we dissect medial to the ureter and lateralize the ureter, that will detach it from the peritoneum. You can follow this dissection of the peritoneum down to the uterosacral ligament. Medially, we can see the hypogastric nerve fibers and dissect this structure out. Here we can see the ureter laterally and the hypogastric nerve medially. We can follow the hypogastric nerve cephalad as it reaches the sacrum and the presacral space. If this area isn't exposed yet, blunt and sharp dissection might be required to expose the bifurcation of the aorta. The common iliac artery is identified here with the branches of external and internal iliac arteries, with the ureter crossing over. The middle sacral artery is seen, and the hypogastric nerve plexus is also visualized medially. The next space is the space of RSus. To enter this space, we can place downward traction on the peritoneum overlying the bladder, and an incision is made in the peritoneum superior to the bladder and extended laterally on either side to the level of the medial umbilical ligament. The areolar tissue is dissected until Cooper's ligament is seen. If we continue with blunt dissection, we can see the white fascial line, which is the arcus tendineus, medial to the obturator internus. This runs from the pubis to the ischial spine. This dissection is performed on the opposing side, which exposes the urethra as well. Here we can appreciate the insertion of the urethra into the bladder and arcus tendineus bilaterally. In this image, we can see the insertion of the ureter into the bladder as well. Let's finish up our dissection by reviewing the ischial spine and pelvic nerves. Here's a drawing of a portion of the pelvis with some critical anatomy. Let's start by identifying our muscles, which includes the piriformis, the obturator internus, the iliococcygeus, and the levator ani. Next, our ligaments can be identified, including the inguinal ligament, the sacrospinous ligament, and the sacrotuberous ligament. The internal iliac artery is visualized cephalad, which we have already dissected in our dissection. Branching off the internal iliac is the internal pudendal artery, which courses superficial to the piriformis muscle and deep under the iliococcygeus and levator ani muscles and exits the pelvis through the greater sciatic foramen. The pudendal nerve can also be identified coursing alongside its artery. The ischial spine can be found by following the arcus tendineus posterior and lateral. The ischial spine lies in the vertical plane below the obturator canal. We can identify the sacrospinous ligament running medially. So let's enter the space lateral to the sacrospinous ligament. If we dissect here, we can see the pudendal nerve running along the medial edge where it exits the greater sciatic foramen. Here's our drawing again to remind us of our surrounding anatomy and the location of nearby structures. Dissecting laterally to the nerve, we can see the pudendal artery and vein. We can also see the posterior femoral cutaneous nerve superior and lateral to the pudendal vessels. If we follow the posterior femoral cutaneous nerve cephalad, the sciatic nerve will be identified. Now here's another drawing that demonstrates more nerves in the abdomen and pelvis that we will be dissecting. First, we can identify the psoas muscle and the iliacus muscle. Working medially to laterally, we will identify the genitofemoral nerve coursing along the psoas muscle and has two branches, the genital and the femoral branches. We will then identify the lateral femoral cutaneous nerve along the iliacus muscle. The most lateral nerves we can appreciate here are the ilioinguinal and the iliohypogastric nerves. Now let's move on to the dissection of these nerves. If we look lateral and cephalad, we can identify the psoas muscle and the genitofemoral nerve on the medial aspect. Next, let's incise the adventitia on the lateral aspect of the psoas muscle. If we retract the psoas muscle medially and posteriorly, we can see the femoral nerve as it runs parallel to the psoas muscle on the posterior lateral side. If we continue the dissection parallel to the nerve, we will see the lateral femoral cutaneous nerve. If we continue this dissection deeply, then we will identify the iliacus muscle, lateral to the femoral nerve. We'll see the lateral femoral cutaneous nerve lying on top of the iliacus muscle, and we can appreciate its branches as well. This dissection can be followed caudally until it exits under the lateral aspect of the inguinal ligament at the ASIS. Here is another view with more pelvic nerves. We can see coursing over the psoas muscle is the genitofemoral nerve, and its branches are visualized. Let's identify all of our structures again. So here's the psoas muscle that we have retracted medially to expose the femoral nerve just underneath, and then lateral to the femoral nerve is the lateral femoral cutaneous nerve, followed by the ilioinguinal nerve and then the iliohypogastric nerve. Here's just another view of those pelvic nerves, as they can be very challenging to find in certain specimens. And here's our drawing again to remind ourselves of the anatomic relationships.